Hi, dear friends from colleagues from across the globe. I'm Dr. Sanjay Jain. I'm practicing implantology since last 25 years here in India, in a beautiful city known as Pune. I'm going to share today about my presentation on Epikut, how to master Epikut and the safe techniques. It's a pleasure to welcome you all for this beautiful webinar. It's going to be very informative, and I promise you the next 15 minutes of my presentation will definitely enlighten us about how we can master Epikut and what techniques we need to follow in our clinical protocol for the safe and effective application of this most taper implant. Before I get into my clinical slides, I would like to emphasize a more on a system that's been so beautifully developed, and if we can follow the right protocols, how effective is this particular implant in our routine day-to-day practice? So I'm a Clean Implant Foundation for India, ambassador for them. I also do a lot of cases on dynamic navigation here in India. I was their first master trainer. In fact, I have done the first Epicute dynamic navigation implant of India, and I'm going to present that video to you later on in my presentation. And also, I have the privilege of being an ambassador for S.I.N implants in India. So when we talk about implants, basically we are not only looking at the company, the service, but what as a clinician we are more interested is about the design and the ease to use this system in our day-to-day practice. And science has proven beyond doubt that most taper connections make our day-to-day clinical work much more easier. Implants which are designed with such precision of cutting, comprehensive and aggressive thread design helps us in achieving primary stability, which again is a key factor for the long-term survival of implants. Since there are double threads with inverted support, the primary anchorage that you get in immediate extraction sockets with this Epicute implant system is just mind-blowing. And later on, we'll see how these systems make our routine clinical workflow in implant dentistry much more easier. Because of its exclusive macro geometry design, it's an ideal solution for immediate loading, low density bones, especially in zone 3, zone 4. Also, wherein the density of the bone is not great enough and you follow the proper protocols, that's where I'm going to talk about the safety and how we can master this implant and achieve greater results day on day. It can be placed in all bone types. You just need to know the density of the bone and accordingly you choose your drilling protocol. Okay. Now, when we talk about Mohs taper, basically it is the angulation wherein the implant and the abutment fit together. And Epicute Mohs taper feature the best-selling angle in the world. Before we get into it, for a lot of other clinicians who are still doing conical connections, and I don't know if somebody is still doing external hex, what is Mohs taper? Basically, it's a designed by engineers, which has been implied in implantology. It's basically friction fit, self-locking conical connection between the implant and the abutment. Typically, this design taper is 5 to 11.5 degrees. Now, why is this important? Is because we see with our routine cases, what happens maximum is screw loosening or fractures at the implant abutment level. More importantly, because of the leakage, we do see a lot of high incidence of periimplantitis and perimucositis. Now, the key features of Mohs taper, as I said, is a conical connection, and that creates like a cold wedge effect. Because of the friction fit, it's not just relying on the internal abutment thread, but also on the geometry of the abutment and the implant. And that results in long-term stability, because the forces are dissipated in such a way that there is not of bone loss happening around the neck of the implant. And because the angle is small, less than 11.5 degrees, less than 11.5 degrees, this enables the self-locking property of an implant. Why do we prefer most taper? Now, as I mentioned to you, I have been practicing implantology from 25 years. I started my journey with external hex. Then we realized the difficulties we had. We switched over to internal hex. Then we realized the difficulties we have. Then some companies modified the internal hex with another kind of interlocking system. But all this causes trouble. So why most tapers preferred? One, it reduced microbial contamination that got a good seal. Friends, let me tell you something. Implantology is just not focused on osseointegration, but also mucosal integration, or what I would call as a biological seal. It's really important that our implants have a great biological seal around the implant abutment connection. Once your biological seal is perfect, the chances of micro leakage, the chance of periimplantitis, bone loss, all that is taken care to a larger extent. Because of its minimal abutment micro movement, there's high stability of the implant prosthesis. And since there is a passivity in the fit of the prosthesis, it can be easily retrieved. Definitely with those retrievable screws, it's much more simpler. And as I mentioned to you, because of the lower incidence of periimplantitis that is seen in most tapered design of implants, we do definitely see a long-term success. Another beauty about this is the cervical microthreads. Now, these microthreads are designed so that the bone implant contact improves. One. Second, it is to dissipate the occlusal forces, especially the shear forces, which in otherwise in an internal hex or in other system, it causes crestal bone loss. And this is very efficient in transmitting loads to the marginal bone. And that's why you see a lot of bone reabsorption. The risk of bone reabsorption is negligible. The other good part about Epikut system, especially the one that I'm using and that's available in our country, is the double acid etch. Now, this double acid etch, no doubt, makes it more micro rough that ensures faster osseointegration because bone is a very dynamic tissue. The more uniform roughness you have around the threads of the implant, the faster is the osseointegration. The more polished surface, the more flat surface, the lesser the osseointegration happening in that area. And because of the greater contact between the implant body and the bone, it reduces the risk of bone resorption and it prioritizes the peri-implant health. When we talk about double threads, what I wanted to emphasize here is the V threads with inverted support, and they resist the traction forces. So these are more efficient in stabilizing the bone, especially in cases of immediate extraction sockets wherein you engage the palatal bone. And the double threads ensure greater rotation of the implant and the speed of its installation. So when you place an implant, it moves in nicely, smoothly, but at the same time engages the palatal bone very effectively. That results in better stability. And because of these cutting threads, these uh, threads basically help us in the insertion speed. More importantly, because of the sharper double thread, we get better anchorage. So we get good stability, we get good anchorage, and with the apical portion of the implant designed in a way wherein it creates a great support and stability for areas where the bone is thin. So it really does not cause microfractures. That's what is feared, but in fact helps in engaging that bone, resulting in both better anchorage and stability. Now, another good part about these systems, especially the ones with most design, most taper, is the platform switch. And what is basically platform switch? If we look at this slide, What we understand by platform switch is the diameter of the abutment is smaller than the implant platform, and that results in pushing away the inflammatory cells from the crestal bone, and the crestal bone is kept intact, and that is one of the first signs of a stable implant, especially after the implant has been loaded. We don't want bone loss to occur around the neck of the implant. And this platform switch, as you see in this RVG here, it's a patient of mine. It's been 6 months. We have loaded this case, and you look at the bone above the platform of the implant and beautifully hugging the most taper of the prosthetic platform and creating great stable soft tissue there. So it helps in protecting the crestal bone, which is under load. That is after you have loaded the implant with the prosthesis. It maintains the 3 to 4 mm of biological width that's mandatory in cases of implant clinical cases. It reduces the inter-implant bone loss, but it again depends that you need to follow the safety margin of 3 mm distance between two implants. So in Epikut also, if you're placing implants too close to each other, you do see some amount of bone loss. So do not forget that the basic knowledge of placing implants, following the rule wherein two adjacent implants have to be placed with a distance of minimum 3 mm, should be followed. And as per the European Academy of Osseointegration, platform switching definitely influences very much on long-term tissue stability in a very positive way. And the good thing about this surgical kit is this is one kit for all the three different varieties of Epicure that you want to place. As I said, I put more of DAE, that is double acid etch. Design is simple. The beauty is it's been mentioned very clearly on the kit also, depending on what bone quality that you encounter where you have to place an implant and till what should be your final drill. Now, that is something so very important. And this has to be taught not only to the clinician, but also your chairside assistant. Okay. What I do in my practice for following better safety protocols, especially with such a beautiful system as Epicut, is I note it down and I paste it behind my chair wherein I'm working, and I make sure what should be my final drill design. And that is as per what implant we are placing. Okay. Then all drills have like diamond-like carbon, so they reduce heating, more endurance. But again, please follow proper irrigation. Just because the company says that they're diamond-like carbon and you don't use irrigation, you're going to create heat. Any heat at the osteotome site can result in bone loss, and that is one of the reasons for implant getting failed to get an osseointegration there. Okay. Now, these comes with a lance drill. So the first drill is a lance drill wherein you can optimize your surgical steps, then your sequential drilling. And as you see here very clearly, the soft, medium, and hard, as per the diameter of the implant, what should be your drill stop or what should be your final drill in that situation. Uh, all these drills have got depth indication and they can be checked on a real size draw in the kit, and they're at every millimeter. Now, when we do see these designs, I know a lot of clinicians will have a question, "Okay, doctor, when we drill it with the irrigation around, we really can't see the markings." That's why Epikut has come out with a beautifully designed stop drill kit, which they call it as a safe drill kit. And that's what I'm going to emphasize on today. So whenever you are doing an Epikut system, please make sure that you use this safe drill kit. It's a beautifully designed system wherein it offers greater precision, safety, and it reduces your surgery time. Basically, there are 32 stoppers uh, with all color coordinates, and it's easy for technical identification. And the best part is, since you're doing most taper, always select the safety drill or the drill stop 1.5 millimeters above your planned implant height. So if you're going to place a 10 millimeter implant, use 11.5 safe drills. Okay, these are drill stops. These are beautiful, well designed. Do not, because since they're not made with metal, they do not get corroded, they do not get rusted. It's easy to clean, they fit in easily. The beauty about this safe drill kit in Epikut system is the same drill can be used for two different or three different diameters of the drills. So the first drill, which can be used for the lance drill and the pilot drill, and then you can go to the next one, which is the first one, the darker gray, the lighter gray. The lighter gray you can use it for the next two drills, and then when you come to the whiter safe drill, that you can use for another three drills. So it's not that with every drill you need to keep changing it. Okay, and since these come with perfect fit and they have got great resistance, it guarantees greater durability of the kit. And for me, it's mandatory to have this kit, especially when I'm doing freehand implant dentistry and not with dynamic navigation. You see this one video here of a recent case. Now, this is a safe drill that I've used. And you see this, in spite of me trying to push the handpiece in, that thing prevents me to going beyond the desired depth. A situation like this, you see it, more close-up view, and see this, just fits in, does not go beyond that. And when you see these radiographs, you realize I kept a safe distance from the intraalveolar nerve canal. We decided to put 11.5 diameter implant. I used the 13 millimeter safe drill kit. And if you look at this last radiovisiograph, that is the RVG, you'll see my implant as per the protocols submerge from the crystal bone. It's 1.5 mm below, and we have got a good platform switch around it. The implant is snugly held by the bone all around. Okay, it has got 5 different platforms, and the beauty about this is the process is just simple. One prosthetic design for every diameter of the implant. You can start with 3.5 all the way till 5. Depending on what situation you're doing, you select your diameter of the implant. Company has few protocols, but I also recommend that do not use 3.5 mm implant in a posterior zone. Use anything beyond 3.8. Preferably, if the bone width and height is good, please go ahead between 4.5 to 5 diameter implants, and that will give you more bone implant contact. So when we talk about implants, we have 3.5, we have 3.8, 4, 4.5, and 5. And you look at it, the lengths are from 8.5, 10 mm, 11.5, 13, and 15. The beauty about this system, as mentioned in this, is depending on what diameters you can use this. So for every clinical situation, you have a diameter ready. Just follow the protocols, especially knowing the density of the bone, application of the drill, safe drill design, and more importantly is what should be your drill speed, that the implant handpiece speed. Okay, we go ahead. This is how we place implants. Where should we put 3.8 diameter implants? 3.75 is for the external X, which we are not going to talk about today. 4.5 millimeters in the posteriors, in the premolar zone, and you do place 5 millimeters in the posterior zone. Epikut also comes with a fully guided surgery kit. I haven't used one, but what I have spoken to other ambassadors and other clinicians who have been using this is they find it really great. Since I have a dynamic navigation in my system, I prefer doing most of my implants with dynamic navigation. But for people who would like to continue with Epicot design, this is really very good. Highly recommended. The other good part about Epicot is the way this implant is dispensed in a very easy to use sterile pack. Uh, I have never had any problem to get access to the implant with the handpiece or manually. And with the beautifully designed 2 mm of cover screw, you tend to get a good uh, seal of the implant access hole. And this keeps in the separate compartments. And the good part about it is it has got its own driver and it rotates until the perfect fit is achieved. Okay. Now I want to talk more about the surgical protocol and then we'll go on to my clinical cases. Now, very important to note that this surgical guide was developed by trained professionals with the sole aim of facilitating and simplifying the installation of implants so as to minimize the possible errors before the surgery, during the surgery, and after the surgery. It's important for us to understand there are 5 protocols which I want to emphasize in this webinar today. And that's what basically is my topic, mastering Epikut, safe and effective techniques. First and foremost, please make sure that the drill system that you're using follows the implant protocol. Okay. Second, the drilling sequence. So this is really important. It is not something wherein you pick up a drill and you go on drilling with as you do with other systems. Here, we have to understand 2 things. One, the density of the bone. Second, what diameter of implant are you placing? So when we have soft bone types, as you see on this slide, our first drill, that's the Lange drill, is only at 1200 RPM. The rest of the drills, the company says 800 RPM. I honestly recommend all the clinicians, please go ahead and do it at 500 RPM. You get much more better anchorage. Okay. So when we talk about soft bone types, so when I'm doing a 5 diameter implant and you see here, the final drill I'm using as a 4 drill. So 4 diameter. So for a 5 implant by diameter, I'm using the final drill. That also depending on how soft the bone is, the final drill will be FHI 40 and nothing beyond that. So always and always in a soft bone, we drill at least 1 or 2 diameters smaller than the diameter of the implant that you've chosen. So if you use a 3.8, then my final drill will be 3 drill. So if it's a 4, my final drill will be something around 3.3. This is how the protocols have to be followed. For the initial few cases, for the clinician to get better understanding of the system, please make a note of it on a small sheet of paper, on a stick-on, and stick it while you're doing the surgery so that you can go through it why before you start, during the procedure, and then you're sure that you have created an ideal bone implant contact for our implant system. For medium types of bone, it's ideally recommended that you should use, suppose if I'm using a 3.5 diameter implant, my final rate will not be the 3.61, it will be 3.3. And these are beautifully coded with alphabets A, B, C, D, E plus, F, G, H. And following this, including for hard bone types, makes it much more easier, much more simpler. And I can assure you, if we follow these drilling sequence at the RPM that's been mentioned, trust me, friends, you will never ever get an implant which is rotating after your final osteotomy is done and after you have put your implant and torqued it. The implant will always, most often, will give you at least a torque of more than 40 Newton centimeter. You'll see in my clinical cases how beautifully we have achieved great torque in immediate extraction situations. Third is the implant installation. Okay, first surgical protocol is a good drill of the same implant system. Second is your drilling sequence. Third is the implant installation. What do we see here? Let's not talk about external hex here. I'm going to talk only about Morse taper. Implant should be inserted at 20 to 40 revolutions per minute, rotations per minute without irrigation. I get, as I said, more than 45 Newton torque centimeter almost every time that I've placed Epikut in an immediate extraction situation. Sometimes I did achieve a torque of more than 70, company says here 80, but it's amazing. Fourth is use of drills for up to 50 osteotomes. What does that mean? Every drill that has been designed, although it is diamond like carbon, which Epikut claims, the company claims, and which I believe is one of the finest way to manufacture drills, is because it also collects patient's autogenous bone. These drills do not let autogenous bone get wasted. It gets collected, which can collect it and use it for your bone augmentation in that particular situation. Company recommends that you should not use any of the drills beyond 50 implant that you have done, because once the drills get dull and once the sharpness is lost, you're going to apply too much of pressure, too much of heat can be generated, and that can result in bone loss around that implant. Fifth is how should be your implant, especially when you're doing a Mohs taper. Your implant should be at least 1.5 to 2 millimeters below the bone crest. I do not recommend to go beyond 2 millimeters, but definitely do not be at least supracrestal. Impossible. I would never recommend that, because that will result in a lot of implant being seen. Complete Mohs taper of the prosthesis will be exposed, and that can be a trap for the plaque accumulation. So make sure your implant is at 1.5 to 2 mm below the crest of the bone. So if you have a 15 millimeter bone height, in that case, use 11.5 mm implant, because you need to add 1.5 mm of the crestal bone, and your implant will be at 13 millimeters. So please make a note. This is another safety tip that I'm sharing with you. Do not choose an implant depending on what length you have, but add 1.5 to the implant length and then decide how much of bone you have, and accordingly you go ahead and place it. Now, when we talk about immediate loading, that's the fifth point, is what should be the insertion torque? It should be 45 to 80 Newton centimeter torque. The torque should be revolutions per minute. We should get something like an implant stability of 70 ISQ. A minimum implant length should be not less than 10 millimeters. Okay, so 8.5 till date, I have not done any immediate loading. All my implants are beyond 10, maximum is 13 millimeters. In a maxillary zone, I've placed 15 millimeter implants and I've got great results. Immediate loading within the 48 hours is ideally recommended. In case of delayed loading, make sure when the insertion torque is less than 40 Newton centimeter torque, wait for some time. Sometimes you need the density of bone to get better or better densified. And then ideally you should wait 3 months for mandible, 4 months for maxilla, and that's when you should go ahead. And what are the main clinical conditions when you do this? Absence of primary stability. Uh, Controversial. Some clinicians across the globe says, no, if your implant does not have primary stability, just take it out. What I would recommend is, if you're going with a Mohs taper design and it's below 1.5 from the crest of the bone, and you have got something around 15 to 20 Newton centimeter torque, and you feel that implant is slightly still mobile, just leave it there. Come back after 3 to 4 months, depending on which arch you're doing, maxilla or mandible, and you'll see your implant is very well osseointegrated. Uh, or areas where there has been some kind of a bone regeneration done, that's where you need to go ahead and do delayed loading. Also in patients who are diabetic and smokers. Before I get into last few slides of my clinical presentation, let me tell you something. Across the globe, we are definitely seeing a change in the paradigm in implantology. And no more are the clinicians or researchers talking about survival of implants. They all are talking about long-term biological stability. And to achieve this biological stability, as I mentioned to you at the start of my webinar, is not only osseointegration, but biointegration, the mucosal integration. And this clinical shift in implantology is going not just bone centric, but along with bone centric, it is the soft tissue and the connection design that define the longevity of any implant system. For a clinician like me, what do I look in a system? It's stability, aesthetics, and how easy it is for the patient to maintain. And a system like Epikut gives us all these three in addition to all other great features that this implant system has in its practice. So let's look at double acid etch Epikut clinical cases. This is my first case where if you look at the preoperative edentulous ridge, I had a buccal deficiency. This lady had undergone extractions. She did mention to her that the extraction was very traumatic. And you look at the adjacent teeth, which have had some kind of a PFM crowns, but they've all been made flat. And we did advise her to change this, but since she was referred to us by another clinician, we said, let's first go ahead and place the implant. So what I did here, after we exposed the bone, we realized that the bone is kind of a triangular in shape. We went ahead, we did use osteodensification burrs by a company known as Densa. We densified the bone. That's when, after the sequential osteotomy, we went ahead and placed our implants in this particular case. So it's 1.5 mm subcrestal. To see this, we place the healing abutment. And if you look at my suture, I have modified my suture design so that I can get a better biological seal around the implant. And you look at the implant, the most taper helps us in achieving this better biological seal. This is the clinical picture I wanted you all to uh, emphasize and have a look at it. And you will see a beautiful peri-implant tissue. You see the way the tissue has adapted around the implant, and what you see is a beautiful Morse taper design wherein my abutment is just going to go in and fit in. With the digital dentistry happening across the globe, what we are looking at is how nice we have achieved this scan body imaging, send it to the lab, got a beautifully screwed in processes made, and this is how it fits in the patient's mouth. Oh, I think I skipped one slide. I think I'll just come back to show the clinical picture. Let's go to the case two. This case has been done recently. It was a premolar extraction, and we went ahead and placed the implant subcrestally. That's how you see again another implant placed. This was placed almost like 2.5 mm subcrestally. I wanted to get a better anchorage. This is a 13 millimeter implant that we have placed. And you look at the kind of biological seal that we get in these situations. Let's look at this very interesting case. And this is elderly gentleman. He had road traffic trauma. A bike fellow on his morning walk came and had a bang on his face. He lost his existing prosthesis. The other two molars also were bad. They had cracks, and he had got a lot of bone loss around. So we thought of first initializing, thinking of grafting that area and going ahead and placing implants with a deficit bone, add a bone there. Patient wasn't keen on any kind of additional surgery. Since the molars and the premolar were indicated for extraction, we said, okay, let's get them out. And then we took out the teeth. We preserved as much as possible the patient's autogenous bone. We flattened, see this? We flattened the crest so that our nose taper can fit in precisely. And we have a uniform platform for our prosthesis to fit so that we need a good soft tissue seal around it. Okay, that's an implant being placed. Let me tell you, friends, all this you are seeing right now on the video is implants done immediately in an molar socket. We extracted molars, both the from the 6 and 7, that's the first and the second molar. The second premolar, we went ahead, did 3 implants, got a good torque. This is the patient's own autogenous bone that I'm grafting after I place the healing abutments. So after the healing abutments have been placed, I'm using patient's own bone that we could get from the drills and also with the initial alveoloplasty that I did around in that area. So that's how we sutured it up, continuous sutures, and this is how the patient walks in after 3 months. So this case, we didn't load it. Although I got a initial torque of stability of 40 Newton centimeter. But since I knew this man hasn't got much of teeth on the other side, and if I give him teeth, he might just misutilize it. So we said, hold on, we'll wait it for 4 months. That's when we got beautifully the implant mucosa around the soft tissue mucosa around the implant. Again, with the design, we did give a cantilever. Now, why did we give a cantilever? We had three implants. We checked the AP distance with the lab in mind. That means the lab technician's design in mind, because the patient wasn't keen on any kind of bone grafting procedure with the lateral canine and the first premolar that he lost, the canine and the first premolar that he lost. So we went ahead and gave a cantilever to this case. This is the clinical picture. Look at the soft tissue that has got adapted. Look at the adequate amount of keratinized mucosa, how it's holding on to it, and the patient goes home satisfied, not just with your implant procedure, but also with the long-term stability of the soft tissue around that implants. Let's look at the next case. Uh, a highly diabetic patient who recently underwent cardiac therapy. He was on ecosprin, that's aspirin, but we did take a consent from his physician and cardiologist. We went ahead, extracted his teeth, place immediate implants. And you see in these clinical slides, every implant of mine, I'm getting more than 45 Newton centimeter torque. That's because of the beautiful thread design of the implant. And that's where it's so helpful in these situations. Again, autogenous graft. After I place my healing abutments, I grafted those sites.
Yeah, you can take a little from the canine zone where I've made it easier for you. Anterior and
Okay. And we went ahead, grafted these sites, placed the membrane, sutured it up. Again, the suture design is basically keeping in mind that my implant need to have better soft tissue seal. So utilize as much as possible the attached gingiva, hug it around the implant so that what we see from how bad the teeth were after the extraction and after the implant placement. This is the radiograph that you see, and you see here, the teeth were badly broken. This is the safety drills that we did. We checked for the sinus lifts. We went ahead, did indirect sinus lift with the posterior two molar implants. With the anterior one, we went ahead. This is how we had the digital design in place. We went ahead. That's how the prosthesis came from the lab. Okay. Since all are 3D printed, we went ahead, customized the abutments, beautifully zirconia-based prosthesis were designed for this individual. Now let's look at one of my earlier cases, which I did with Epikut, and I started with an all-on-4 case. And this video is so you saw this all-on-4 case wherein we started with bad lower arch teeth. We explained to the patient about getting a total extraction done with a lower arch. The maxillary teeth were okay, but the prosthesis was very bad. We just redid the process with acrylic in mind because we needed to go back after a few months and then switch over to a better zirconia-based prosthesis. Lower, we went ahead, extracted, placed immediate implants, followed the all-on-4 protocols, went ahead and gave processes within the first 48 hours after the implants were placed. Now let's look at this case, which is India's first dynamic navigation case done with Epikut system. And let's see how beautifully we could get this. Okay. This also is self-explanatory. So this is a very high aesthetic case. And let me go through the video first, and then I'll explain to you. So this is the tooth number 11, that's the right central incisor, endodontically treated, had a internal resorption happening. There was some amount of palatal bone loss that we saw in this case, and that's when I decided to use our Epikut system. So this is where I'm using my dynamic navigation system from Navident in Clarenov, Canada. What I'm doing right now is tracing four teeth to get a score of 100. So they become the fixed reference points. And that's how earth traumatic extractions happen. First, we use the periotomes, and then just with the forceps, we had taken the tooth out. Then sequential osteotomy with real-time tracking was done. So you see in the screen, I'm absolutely getting a bullseye. So this is 3.8 by 13 millimeter implant. And we went ahead and you look at that RVG and look at that torque that we got. We got a torque of almost more than 50 Newton centimeter. Again, patient's own bone, place it there, temperature center place, immediate provisional processes made with composite. Now, this would have been much better. That I'm planning to do it when the patient comes back. Reason we went ahead and did just this much, giving a lot of diastema space on both the sides, is because I didn't want to connect my implant temporary crown to adjacent teeth. One, for better plaque control. Second, I'm looking more at getting the contour right so that I do not lose the papilla support there. As a periodontist, I know how difficult it is to regenerate a papilla. So these kind of temporary prosthesis helps us in achieving a good health of interdental papilla there. So what should be the take home message? Now, the last 40, 45 minutes that I've spoken to you, I believe in one thing, that patients' health and patients' well-being should be at the forefront of our clinical protocols. I mean to say is our case selection is number one criteria. Following a proper case selection, selecting the right implant is important. Third is following the protocols for safe and efficient application of that particular implant system. And I've explained to you in last 40 minutes how beautifully we can plan each and every case that comes for practice, keeping in mind the density of bone, use of safe drills so that you do not cause any damage, following the drilling protocols, at what revolutions per minute you have to keep. And when we talk about predictable implantology across the globe, what's shifting is people are looking more at conical platform switch implants because science has proven beyond doubt that there is better implant stability, better implant connection. We need to see adequate soft tissue volume around our implants. If not, friends, my suggestion is please go ahead and do graft, do connective tissue grafts, go ahead and place synthetic grafts, but please look at making keeping adequate soft tissue volume around the implant. A keratinized tissue is far more predictable, far more uh, stable to keep the biological seal intact than an implant which is devoid of keratinized tissue. Passive fit prosthesis should be the key because any active prosthesis can result in undue trauma to the implant, and that could be one of the reasons for a prosthesis failing even after better osseointegration, especially after you have loaded that implant. Screw retain prosthesis in situations where it's very much possible, please go ahead do it. In situations like an anterior zone where it gets difficult, then please go ahead do crown retain, but make sure that your implant prosthetic design is more aesthetic and respecting the tissue around that. Safety first should be the motto. As I mentioned to you, following drilling protocols as per the density of bone, achieving better primary stability should be focused on. Safe drill set and proper implant planning. These three are the key take-home messages from today's webinar. And I believe that if we have to plan and do it, an implant system should follow your clinical decision making and not the other way around. So do not get carried away with a lot of Insta or Facebook where they're showing all kinds of implants being done and having it. I believe understand the design of the system that you're doing, understand the clinical protocols, the surgical protocols. In case of an Epikut, what I've achieved is high primary tissue stability. I've placed implants in, you saw both the cases. One was a mandibular immediate extraction, one was a maxillary immediate extraction, and both the cases we got torque of more than 45 Newton centimeter. You saw one maxillary anterior case, which I showed with dynamic navigation, getting almost close to 45 Newton centimeter torque. We gave an immediate prosthesis, all that. And most taper in aesthetic zone is one of the best solutions. Based on these two, three reviews, I prepared this presentation so that I can give you evidence-based knowledge. And since I'm a part of the ambassador team at Clean Implant Foundation, I know how important it is to have the best implants placed in your practice. This is my details. In case if you have any queries, I reside in India in a city known as Pune, which is around 110 miles south of Mumbai. It's also known as the Oxford of the East. We have a lot of education institutes, and dentistry here is definitely at the top as of now. Thank you so much. I'm really grateful to the team at Epikut at S.I.N Implant for giving me this opportunity to share my knowledge on safe and effective applications wherein you can master this system, which is designed keeping in mind every density of bone. So solutions and innovations gives us new smiles, and smile is what we want to see on each and every face that we come across in our clinical practice. Thank you, friends, for listening to me for the last 55 minutes. Colleagues, implantologists across the globe, I'm sure this presentation must have given some food for thought, and there might be some queries. And if there are, we are open to the question answer session now. I'll be very happy to answer your question answers. And in case if I cannot, then I assure you, I will get back to you with the right scientific evidence-based answer to your query. Uh, Thank you once again for being a great audience. Thank you.